All right, morning again, and thank you everyone for coming to this, I think, exciting session on cell-free DNA and minimal residual disease. I could see many people who are already perusing the posters, and that's great. And we will have two discussants discuss the 8 or 9 different posters here. The first discussant is Yara Abdou from the University of North Carolina, and she will take us through the first few posters.
Well, good morning, everyone. Thanks for being here, and thanks for the organizing committee for the invitation to speak. These are my disclosures. All right, so our current paradigm for risk stratification classifies patients into low or high risk categories based on clinical, pathological, and/or predictive genomic tools that we use at the time of diagnosis or surgery. And this approach is really limited because it doesn't take into account dynamic disease changes, which leaves room for potentially over-treatment of our low-risk patients that have been potentially cured and under-treatment of our high patients. So definitely there's an unmet need in addressing risk stratification, optimizing treatment for our breast cancer patients. So this brings us to the new frontier, which is ctDNA-based MRD detection. By definition, MRD is residual disease on the molecular level, where there's fragmented tumor-derived DNA detected within the bloodstream, but there's no clinical evidence of recurrence. And prior studies have shown ctDNA-based MRD detection predicts recurrence with really high sensitivity and specificity, making it a strong prognostic tool for predicting recurrence in breast cancer. So if we incorporate ctDNA-based MRD assessment into the stratification process, it adds a more dynamic and real-time dimension to risk evaluation, capturing dormant or active tumor biology that our static baseline methods may overlook, ultimately refining risk stratification and potentially enabling personalized care. So where are we now? The Signatera ctDNA assay was approved by Centers for Medicare and Medicaid Services last year for recurrence monitoring in high-risk breast cancer. The RaDaR ctDNA assay was approved by Blue Shield of California also about a year ago for monitoring relapse in all stages of cancer. However, there is no established evidence for or against clinical utility in early-stage breast cancer. Therefore, ASCO or NCCN guidelines do not currently endorse testing. And the most important unanswered question remains, which is, can intervening on MRD or molecular relapse redefine and improve outcomes for early-stage breast cancer? So there are many ongoing efforts looking at this question of MRD interception. However, challenges remain in the implementation and effectiveness of these strategies. For instance, ZEST, which is now permanently discontinued, and CTRAC are both prospective interventional studies that had really high rates of metastatic disease detected upon ctDNA positivity, limiting the clinical utility of MRD detection. This really highlights the importance of having sensitive ctDNA assays and early and frequent monitoring to capture that therapeutic window early on for intervention. And we hope upcoming studies like PREDICT-RD will address some of these questions in order to provide meaningful conclusions as to ctDNA actionability and clinical utility. So I'm going to be discussing 3 exciting posters contributing to the evolving field of MRD, focusing on clinical utility. And last but not least, we're going to shift gears from MRD a little bit and evaluate racial genomic differences in de novo metastatic breast cancer, utilizing ctDNA results from a large multi-center consortium. All right, so starting off with our first poster by Dr. Sharf and colleagues. So this is investigating the landscape of actionable genomic alterations in early-stage hormone-positive breast cancer and their association with MRD and outcomes. This was a retrospective study of 15,000 patients who had longitudinal Signatera ctDNA assay in the real-world setting. So the whole exome sequencing that was used to design each patient's tumor-informed ctDNA assay was used to analyze the presence of targetable somatic mutations. And as you see here, about half of the full cohort and 45% of the ctDNA positive cohort had at least one targetable mutation, with PIK3CA being the most common at about 35%. And when correlating that with distant relapse-free survival, among patients with early ctDNA positivity, so within 2 years from surgery, those with PIK3CA mutation tend to have worse DRFS than wild-type PIK3CA, while the ctDNA negative group had excellent outcomes. So a really innovative integration of genomic profiling with tumor-informed ctDNA surveillance to refine recurrent risk prediction. I think from a clinical standpoint, this provides a compelling rationale for ctDNA-informed therapeutic strategies, and the proposed basket trial leverages this precision approach, tailoring treatment based on MRD positivity and the detection of actionable mutations. I think one limitation is the whole exome sequencing is limited to the primary tumor. Acquired resistance mutations such as ESR1 and many others arising during therapy may be missed and hence underreported in these studies. So I think future studies with more contemporary samples, blood or tissue, is needed to fully capture tumor evolution and resistance mechanisms, especially if we're intending to use that for MRD interception. Moving on to our next poster by Dr. Taranto and colleagues. This is looking at the association of circulating tumor DNA with disseminated tumor cells, or DTCs, and outcomes in a population of high-risk breast cancer survivors. So this was a prospective study looking at high-risk breast cancer patients of any subtype as defined here. Patients had annual bone marrow aspirates for DTCs, and DTC-positive patients then enrolled on a therapeutic trial. ctDNA here was retrospectively reviewed using the RaDaR assay on a total of 109 patients, 9 of whom were ctDNA positive. So if you look at the table below, there was no particular concordance between TC and ctDNA positivity. When looking at the swimmer's plot of the 109 patients with ctDNA availability, the ctDNA was strongly associated with relapse. In the DTC negative group, five patients had ctDNA positivity, all of whom relapsed, making you wonder if bone marrow aspirates may miss tumor cells, leading to false negative rates of DTC detection. In the DTC positive group, 4 patients relapsed, 3 of whom had ctDNA positivity shortly prior to the relapse. However, the lead time from DTC positivity to relapse was about 22 months. So what are DTCs? They're tumor cells that detach from the primary tumor, travel through the bloodstream, and lodge in distant tissues, such as the bone marrow. While we know that DTCs have been shown to correlate with a recurrence, it's less clear what drives these cells to transition from dormancy to a more active or virulent state, ultimately leading to recurrence. So perhaps an opportunity here for ctDNA to enhance risk stratification. So DTCs and ctDNA can offer complementary insights into recurrence risk, covering different phases of the tumor biology. DTCs present more dormant tumor cells that may not actively be shedding in the bloodstream and can be identified well before ctDNA detection or clinical relapse, perhaps offering an extended window for early intervention. However, understanding the timing and interplay of ctDNA and DTC positivity will be important for optimizing clinical utility here. All right, so moving on to next poster by Dr. Bonnefoi and colleagues. This is looking at the clinical validity of an ultra-sensitive newer generation ctDNA assay, tracking structural variants to predict relapse in high-risk breast cancer survivors. So this is a multi-center study enrolling high-risk breast cancer patients with residual disease after neoadjuvant therapy, and patients were followed in the adjuvant setting with serial sampling every 6 months. Whole genome sequencing of the tumor samples identified up to 8 structural variants were used to develop multiplex digital PCR assays for MRD monitoring. As you see here, patients with ctDNA positivity had a shorter recurrence-free interval compared to ctDNA negative groups with a hazard ratio of 20.6. Mean lead time from ctDNA detection to relapse was 12 months and up to 61 months. It was 100% sensitive for non-intracranial and non-local relapse, missing 1 brain-only met and 1 local regional recurrence. So out of the 32 patients with positive ctDNA, 13 were relapse-free at the time of database lock. So let's take a clear look at those patients. So 6 patients had ctDNA at the first landmark time point only. So these patients could have had residual signal from pre-surgery, could have cleared on adjuvant therapy, which is exciting, or they could have spontaneously cleared. It's hard to tease out what happened, but these patients probably will do well. The other 7 patients, 4 of them had ctDNA positivity at multiple time points, 2 of whom relapsed after the database lock. 3 patients had ctDNA positivity at the last visit only. And I suspect these patients will eventually relapse and longer follow-up is needed. And perhaps this is telling us that there are longer lead times with SV-based ctDNA surveillance. So these extended lead times can offer a promising window for early intervention. However, longer follow-up is needed to characterize these lead times, and subtype-specific analysis will be important to refine the assay's clinical utility across different subtypes. It potentially offers improved signal-to-noise ratio, as it's more specific for tumor cells, and enhances sensitivity for detecting MRD. However, direct comparison to traditional SNV approaches is still needed to fully validate the advantages and limitations of such assays. And finally, the blood-brain barrier complicates MRD detection in brain-only mets, and it says that we need more strategies that fully capture tumor dynamics in the brain, such as perhaps CSF, ctDNA. Last poster by Dr. Podany and colleagues evaluating racial genomic differences in de novo metastatic breast cancer utilizing ctDNA. This was a large multi-center consortium study of 13,000 patients that had ctDNA results from Garden 360, which were retrospectively reviewed. Out of these, there were 210 white patients with de novo metastatic breast cancer and 38 black patients with de novo metastatic breast cancer, most of whom had ER-positive, HER2-negative disease. So this is a busy slide. In the middle panel, you see alterations found in black patients with de novo metastatic breast cancer overall. And on the right, you see multivariate analysis in the ER-positive cohort, controlling for lines of therapy. And this showed that tumors from black patients had a higher frequency of cyclin D1 copy number variants, GATA3 single nucleotide variants, and cell cycle pathway alterations. And when comparing black patients with recurrent metastatic breast cancer, black patients with de novo metastatic breast cancer were significantly more likely to have cell cycle pathway alterations. So really, it's a large clinical genomic data set revealing potential differences in tumor biology between black and white patients. The differences in genomic alterations between de novo and recurrent metastatic breast cancer supports the notion that de novo disease is biologically distinct and perhaps requiring tailored therapeutic approaches. From a clinical perspective, I think the higher cell cycle pathway alterations suggest potential sensitivity to CDK4/6 inhibitors, and that's important because we've showed in prior real-world studies that black patients have a lower utilization of CDK4/6 inhibitors, highlighting a treatment gap that needs to be addressed. So future studies with larger data sets that include outcome data will be essential for clinical validation and significance. And then obviously looking at social determinants of health is very important because systemic inequities can influence tumor biology and outcomes. So to summarize, the evolving field of MRD is an exciting and potentially practice-changing area in breast cancer. As ctDNA assays continue to improve, we are and must simultaneously explore the clinical actionability of MRD, And to fully unlock ctDNA's potential, we must compare these various technologies within similar cohorts to define the clinical utility across settings. And finally, leveraging ctDNA technology can shed light on tumor biology factors contributing to disparities in cancer outcomes. Therefore, it's important to validate this technology across diverse patient populations. I'd like to thank my colleagues, all the presenters and authors, and most importantly, our patients who inspire and guide our research every day. Thank you.
All right, now it's time for questions. Do we have any questions from the audience? Please walk up to a microphone, or you can send it to me from your phone, and I get to read it up here. Here we go.
Good morning, it's Nick Turutoglu. I'm a medical oncologist in Greece. I have a question for anybody in the panel. As a clinician, I always wonder what may be a false negative rate in these tests, and how do we define sensitive, ultra-sensitive? You know, if you take the internet as an example, when we first started, it was 20 megabps was fast enough. Now 1 giga is not fast enough. So is there an upper limit to the detection, or a lower limit to the detection that we might achieve with these tests?
I think you've identified a problem that we have here for clinical utility. I think we need to standardize our threshold for ctDNA detection. I think every assay is doing its own thing, and we won't be able to get to clinical utility unless we standardize that. I don't know if anyone else has a comment.
I agree. I think this is a really important question, and it's a question that's really hard to answer in the absence of prospective clinical trial data. I think in the retrospective analyses in breast cancer, unfortunately, we don't usually have testing that is done at regular intervals, or testing that is done simultaneously with scans. And so to really understand the true sensitivity and specificity clinically of an assay, I find so challenging. Of course, there's the technical sensitivity, and that varies by assay and for indication. But I think this is a really important point, and why we are all very motivated, of course, to work on the prospective trials.
If I understood well, you asked a question about the definition of a false negative test.
Is there such a thing as a false negative with these assays? I saw one of the posters claiming 100% specificity, then I'm not sure about the sensitivity.
I'm guilty for this 100%. It's very simple, because we had 2 patients who relapsed and were ctDNA negative, one brain relapse only, and another local relapse only. So whether you take these events in consideration or not, you have either a 90% sensitivity or 100% sensitivity. But I don't think that we are designing or using this test so far to diagnose local relapse. There are easier way to do this. At least your question about false negative was, I think, quite easy. I will not comment the question of the threshold, if I can. And the question regarding false positive or potentially false positive cases is much more tricky, because we need quite a long follow-up to be able to define the precise accuracy of a test, the PPV and NPV, and we have not yet these very long follow-ups, but that's it. That's what we have.
Thank you.
Thank you. Actually, one thing I'll point out is I believe the FDA gave some guidance just this last week on the use of these tests as a surrogate endpoint for clinical trials, and also sort of reminded us of some biomarker rules and guidelines. So I'll refer people to go look at that, because it's obviously going to be important, right? And certainly these tests are increasing in their use as surrogate endpoints or as endpoints in various clinical trials. So we're going to go over there and then over there. Carl.
Yeah. So you made some very good points about the fact that we need to understand the relative performance of these different tests. And you also made the point that these require large clinical trials that take a long time. So what's the solution for that? So years ago, for the genomic testing ctDNA assays, we did a bake-off. We compared the performance of them with the same samples and showed difference in their detectability and sensitivity. And I'm just wondering if a study were done with these MRD tests that evaluated the evaluability rate of the baseline samples, the PPA and the MPA, the sensitivity and selectivity, would that be adequate to answer your question about the comparativeness of these assays?
Who would like to answer the question?
Oh, sorry, I guess I missed your point. Sorry about that.
Yara made the point that there are many assays out there for MRD. And the clinicians are struggling with how do you compare your assay, one assay to another, right? So so again, you cannot run a large clinical trial and compare two assays. That would be almost impossible to do politically as well as cost-wise. So would data comparing in the same data set, the evaluability rate, that is how many you can actually detect a baseline level in, and then understanding the sensitivity of the assay and the false positive rate, would that information be useful in a clinician making a decision about a given MRD test?
The short answer is yes.
Yeah, okay.
It's a great start, but I think that's a start for one part of the issue. And then the second part, which is the most important part, is what are we going to do with this data? How is it going to be, what's the clinical utility of the data we get? And then I think the next step is trying to intervene on MRD and trying to catch that therapeutic window.
Yeah, fully agree. I mean, obviously getting some sort of comparability would be the first step, because you're trying to compare different clinical trials with different assays. So now if you knew kind of how they matched up to each other, the interpretability of that would be better. And, there are some consortia, both FNIH and BloodPAC, that are doing things like this. So I'm just trying to get some endorsement for encouraging this.
Thank you. Over there.
Hi, Nick McAndrew, medical oncologist at UCLA and former D. Michelle alum at Penn. So, Dr. Taranto, congrats on your work. I think this SURMOUNT study is so interesting, and dormant tumor cells are so interesting. But of course, it's very challenging to find patients who have positive dormant tumor cells, and of course, a bone marrow biopsy isn't a common procedure in breast cancer. So I was wondering, are there, in the SURMOUNT study of the patients who are DTC positive, is there any work being done within SURMOUNT to look at patient or tumor characteristics that might predict higher likelihood of having DTCs?
Great question. So we actually are in the middle of looking at that right now, and we'll be looking at it the next several months. We will also be looking at predictors of ctDNA positivity, though admittedly, given that we only had a cohort of 109 with only 9 ctDNA positive patients, it makes it a little bit harder to parse out those factors. I will say in kind of preliminary analyses, it seems like higher tumor grade and higher tumor T stage and N stage at diagnosis seem to be the most strongly associated in multivariable analysis with DTC positivity, but I think we need to do a little more diving into that.
And is there any plan for like whole exome sequencing of the tumors to see if there are like very specific genomic alterations that are associated with that like ability to invade the bone marrow?
Yeah, it's a really good question. I think it's worth considering, absolutely, just and thinking about kind of what the profile of the single cells that we're finding in the bone marrow is and how those compare to the tumor expression profile, but we haven't yet done that.
Thank you. Over there.
Anthony Elias, University of Colorado. 2 points. One is, of course, our major limitation is what do we do about the positive and the uncertainty that the intervention proposed is actually going to change outcome. And I certainly endorse the basket trial to actually use the specificity of the ctDNA found to try to do our best. The second point is related to CHIP. That is one of the issues in terms of false positivity. You know, for example, I have a patient with a isolated P53 mutation that makes me concerned for potential development of MDS in the future, but probably it's not the breast cancer. In part because usually you don't have single isolated mutations, you usually have several. Any comments on that?
So comments about CHIP complicating
Yeah.
the landscape here?
Yes, because most of the assays don't pick up CHIP.
Yeah, thank you for that important comment. I think that's one of the issues that providers are becoming increasingly aware of, which is important to consider whether the assay that you are using filters for CHIP or not, and how to interpret those results accordingly. There was a really nice ctDNA educational talk session earlier in the conference that brought up that exact point, and I think it's really important. Thank you for bringing that up.
And
Adrian?
Dr. Bonnefoi's poster looked at structural variants based ctDNA assays, and I think that tends to have less of a problem with CHIP because it's more tumor specific, so potentially providing a cleaner signal there.
Thank you. You answered the question beautifully.
Actually, let me jump in here and ask a question of Dr. Podany, which is, so I'm always interested to see possible genetic differences between African Americans and white Americans, and I noticed the GATA3 and cell cycle. Is there any, I don't know, biologic understanding of that, or what do you think about those differences?
Thank you. Oh, you know what? I'm going to use this one. Okay. Thank you. That's a great question. So it's interesting. We're wondering if, because we've seen that those particular mutations and cell cycle pathway mutations in particular, or alterations in particular, can cause more aggressive tumor biology. There's this question now, are we seeing some of the differences in outcomes, the really striking, pervasive, horrific differences in outcomes between Black and white women, especially with metastatic and de novo breast cancer, are they coming from some of this aggressive tumor biology? But the other question is, where are these coming from? Are they coming from the environment? Are they coming from stressors? Are they coming from changes within the tumor microenvironment? And so I think we have to come at it from two ways. One is seeing, are these mutations potentially targetable? So I know that there's some work on GATA3 to see if potentially we can target it in the future. As you said, can we use CDK4/6 inhibitors for these cell cycle alterations? We have to focus on access to care. We have to figure out, are we even giving these patients the treatments that we know work, right? So there's the biological side, and then there's the social determinants of health side of what in the environment is causing the differences. And I don't think we know yet, but I think it's a really interesting question to ask in the future, is what's causing this to begin with, whether it's ancestral, just whether it's germline differences, or whether it's truly like environmental stressors that are causing it.
Thank you. So, Adrian?
Adrian Lee from the University of Pittsburgh. I wanted to ask about the structural variant detection. We don't know why some tumors or cells shed DNA and others do and don't. And I wonder if is there a rationale that those tumors that have high genomic instability and lots of structural variants might shed more, die more, and shed more, and that might mean it might be a better way to detect them because they maybe just shed at a higher level these structural variants than the point mutations. And if you know that.
Joker. I have just no idea. And
you can always philosophize.
I can only thank you for your question.
Yeah.
But
the unanswerable question. One more question right there.
Hi, Jake Layla from Texas Biomed Research Institute. So I kind of want to take the conversation away from the residual side. There seems to be a huge explosion on early risk assessment using cell-free DNA and DNA methylation. I'm just curious, I'm very skeptical of a lot of these results that are coming out. I'm curious from the panel how you guys feel about some of these predictors of cancer. I think it kind of builds on the previous answer about trying to find the environmental influence and how that might cause a tumor. Do you see a future where these can kind of come together, where we can predict and then follow the residual side?
Okay, no one here. That's a hot potato, maybe.
From a clinical perspective, I think if we're a few steps behind on MRD assessment, we're many steps behind on early detection.
Thank you so much.
All right, thank you. Let's thank the presenters and our moderator and our discussant. And now I will invite up our next set of poster presenters and Marija Balic from the University of Pittsburgh. And this section will be a bit focused on ctDNA and tumor evolution. All right, so we should have got a few more people coming up. Almost there. We're gonna have what? 1, 2, 4, right? 4, yep, excellent. Please go ahead. Can we get Marija's slides up, please? What happened to the... We seem to have lost the slide advancer. I don't have it.
Good start.
Yara, might you have it? We're missing the slide advancer.
Oh, okay.
I think there's only a mouse. Oh, I thought there was not mouse.
Okay.
Okay.
Sorry. Well, thank you. Thank you very much. It is a very exciting session, and I'm very honored to be here as the discussant of 4 very exciting posters. The topic is ctDNA in tumor evolution, but you will see some overlap between the first posters and also the 4 selected abstracts that I am happy to discuss. Sorry. Okay. So this is a little technical challenge, but we will get it done. So these are my disclosures, and we have had some very nice introduction by Dr. Abdou before. Just to summarize it a bit, in order to define the ctDNA utility and the possibility to analyze tumor DNA in tumor evolution, just to remind you, the ctDNA is basically our surrogate of different metastatic sites. And as you can see on the lower hand side, basically the tumor stage pretty much defines what we are discussing nowadays, which technology to use for which specific question. You can very nicely see that at the tumor stage 1, there is very little ctDNA in peripheral blood, as opposite to the metastatic disease, where we have a more freedom to choose our assays. But the possibilities of ctDNA, we are very much all aware of that, are great, and it allows us for many different aspects to be addressed as to evaluate tumor response, tumor evolution, subclonality, and even what we've heard in early stage disease to evaluate response to neoadjuvant treatment and then define patients at risk. Okay, thank you so much. Now, a little bit has been already discussed, but just to summarize, how do we choose our assays? This is a nice summary of basically differences, what is currently available. On the left-hand side, you see this so-called tumor-informed testing, and basically these are the assays that are used typically in MRD evaluation in early setting. And there are several differences, and we've already heard in the first part of the discussion novelties which we are facing with novel generation assays. But those are basically personalized assays based on tumor evaluation of one specific patient and then defining either genomic alterations or structural changes, leading to personalized assays which can then be used in the follow-up to determine both response and prognosis. These are, as said, typically used in early stage as opposite to the so-called agnostic testing, where we use assays with predefined spectra, and these can be used pretty much at advanced setting, evaluating our well-known tumor drivers and genetic alterations. And now, in today's world, we are seeing upgrade of even those assays in clinical setting, because all of the available clinically used assays are now having some additional information in terms of tumor fraction. It typically is depending on either whole genome analysis or methylation assays, and adding thereby additional information which will in future add much understanding to our biology of the disease. This picture basically summarizes how the technologies have evolved from one single hotspot mutation over next generation sequencing, evaluating genome profiling of different tumors. But nowadays we are facing more biological information by analyzing open chromatins, by analyzing methylation patterns. And basically, the future will lead to multi-parametric analysis of all this information, and we will see some of the potentials in the next abstracts I will be discussing. So, 4 abstracts have been selected for the discussion in terms of CT tumor evolution, but it is, of course, somewhat parallel to what has been discussed. The first poster I'm discussing is the poster by Linville et al. And this is basically a poster from the classical setting of hormone receptor positive disease, demonstrating the disease which demonstrating the clinical utility of ctDNA tumor testing. This poster addresses serial circulating tumor DNA assessment to predict treatment response and identify genomic evolution in patients with metastatic breast cancer. It is an image 2 study, and the objective of the studies were to first analyze decrease in ctDNA at weeks 1 and 2, so early during the tumor treatment, after initiation of new systemic therapy. And the question, can this predict treatment response at the time of first restaging? And of course, additional very important questions on changes in mutational profile over time using serial ctDNA sample testing. Here on the left-hand side, you can see the design of the study, and this is pretty much a real-world study from tumor board, molecular tumor board assessment of patients at progression. On the right-hand side, you can see the summary of the patients, patients who responded, patients who didn't respond, and the missing information. And basically, the median pre-treatment line of the patients, the majority of the patients were first and second line setting. Some of them were heavily pre-treated with 4 or more lines. You see the distribution, basically the majority of patients were, of course, female. Majority of patients had ductal carcinoma, low percentage corresponding to what we know in the real world with lobular carcinoma, and then the majority of patients postmenopausal. And what has been first shown is basically that you can access the assay used for the analysis was Foundation 1, a diagnostic test as previously used, not the new generation test that is currently being offered in the clinic. And but what you nicely see is basically the corresponding, the median allele frequency corresponding with treatment response, and also the tumor fraction as generated by Foundation Medicine, with a very nice overlap between the two, and after 1 or 2 weeks of treatment, a nice drop for those patients who were responding. And at the same time, the assay allowed for evaluation of genomic alterations, as you can see on the right-hand side. And to summarize those data, actionable genes as ACT, BRCA2, ERB2, ESR1, PIK3CA, and PTEN were detected in 27% of patients. And also the disappearing mutations under treatment were analyzed. And what could be observed that patients with higher levels of ctDNA were less likely to have clinical response. However, those patients who responded by week 1 or 2, there was a decrease in 90%, and those were correlated with clinical response. And there were some emerging mutations, and those were typically found at the progression of the disease. Second abstract is basically a follow-up abstract of what we heard in the previous session, and this is the version 2 of the so-called SAGA provided assay. And we were all excited to see these results and the first presentation of the clinical data from breast cancer. The difference, as we've heard in the previous discussion, is that that the assay is based on the structural variance analysis, basically looking for translocations, inversions, tandem duplications, and large deletions, as opposite to point mutations and smaller alterations in other assays. So this assay was designed to detect tumor-specific structural variants in plasma with ctDNA with multiplex digital PCR. The design of the study can be seen in the lower picture. And here you can see, and this data is very interesting, basically, specifically for the ER-positive disease, because this is the disease where we mostly discuss about the sensitivity and specificity of the assays. You do see that there is, on average, lower amount of structural variants detected in hormone receptor-positive disease. The allele frequency typically corresponds with the time point, with the subtype, and you see the distribution of the allele frequency according to the subtypes, with lowest amount in the ER-positive disease. Of course, an increase with nodal stage and with tumor size. What was really surprising, and I think this data is very encouraging, that the ctDNA was detected in 96% of baseline patients, and median VAF was low, but as depicted here. However, in 96% of triple-negative patients, ctDNA was detected. In ER-positive, although the number of the structural variants, the median number was very low, the positivity was 94%, and in HER2-positive disease, 97%. Now, we can again see this classical picture when ctDNA is detected, that it has a very prognostic significance. However, we should remind us that the number is low, and definitely we have to wait for validation in large cohorts. Nevertheless, sensitivity advantages of these new generation ctDNA assays are promising. Next abstract that I'm discussing is by Grishpan et al., demonstrating data from a very nicely defined cohort of neoadjuvant endocrine-treated patients, plus minus palbociclib, with the objective to investigate the potential utility of baseline ctDNA and dynamic changes during neoendocrine treatment as biomarker to help us to guide systemic treatment decisions. It is a phase 2 Phelps trial. And as said, authors are promising to provide data on ultra-sensitive detection, which we may discuss a little bit later. Now, these are the patient characteristics. The blood was drawn at the baseline and before surgery. We could discuss in the discussion whether more time points were needed. Nevertheless, you could see a very nice correlation of ctDNA detected and patients who are not responding, and those patients who continue to have ctDNA have risk of recurrence. And the data were showing that the clearance can be nicely analyzed. data is summarizing basically ctDNA clearance. It is the first study to investigate the dynamics of ctDNA during neoadjuvant treatment using the Guardant Infinity platform. This platform belongs to the tumor-agnostic platforms. And the question is whether for this setting a more sensitive technology may be beneficial, as we've seen in the previous abstract. But nevertheless, if we aim to use the tumor-informed assays, it has been already discussed that we then miss biologically important information. Nevertheless, this study pointed out that ctDNA has the potential to provide valuable insights into tumor burden, tumor evaluation, sensitivity to endocrine treatment, and of course, what in this case could be analyzed is the emergence of endocrine resistance mutations. The last abstract was, for me, the most challenging abstract. As medical oncologist, it is a real challenge, but also a great opportunity for us to start evaluating biology of the disease under treatment. The abstract by Beagan et al. Focused on epigenomic characterization of ER transcriptional activation via liquid biopsy. Basically evaluating the endocrine treatment efficacy, which depends on the transcriptional addiction of the cancer cells to estrogen receptor signaling, and of course our knowledge that immunohistochemistry and ESR1 mutations are not enough to evaluate the dependency on the transcription, on the ER transcriptional activity. On the lower hand side, you can see the data and basically the concept of the assay, basically focusing on different levels of methylation. And you can see that both promoters and enhancers are analyzed. And I'm sorry, but it is very small, and as said, it is a very challenging essay to understand, and I encourage you to really discuss this with the authors, because this will be a promising essay for the future. Now, the basic of the essay is basically based on cell lines treated with estrogen, and demonstrating which regions are potentially changing during the treatment, both focusing on dependency and upregulation, and evaluating genome-wide rearrangements in response to estrogen exposure. 8 cell lines were first used to generate the assay, and then the generated knowledge was used to evaluate liquid biopsy and plasma, to evaluate basically transcriptional activity, both from FOXA-dependent activity and downregulation. Now, what you can see here is a very complex design of the PREDICT assay and the correspondence of basically upregulated genes and downregulated genes and distraction to basically predict response to hormonal treatment. The authors were able to demonstrate that this nicely correlates to RNA signature, and it is the first assay to really enable us to analyze estrogen receptor dependence in plasma of treated patients. It's just a baseline, but we are very much looking forward to get more knowledge and insight in patients treated with treatments, with estrogen endocrine treatments in the clinic, and to better understand whether with this assay we will be able to predict response to novel agents such as SERDs, or will we evaluate patients who are basically candidates for chemotherapy, not depending on estrogen treatment anymore. To summarize, it is very nicely seen in this session that novel technological approaches allow for accumulating evidence of evolutional analysis. I congratulate all the authors for interesting abstracts illustrating how the future will evolve. However, it is just the beginning of analysis of tumor evolution. Currently, tumor-informed assays are dominating in the early stage setting, and supporting implementation is here to really enable us for precision aspects and to determine who are the patients who can benefit for escalation and de-escalation. But we will have to continue our discussions as previously started. and in metastatic, and hopefully soon, as additive value in early stage, we will see increasing number of trials demonstrating and evaluating the utility of ctDNA testing. Thank you very much.
Okay, any questions? Please send in your questions online or walk up to the microphones. You all did a great job last time of asking questions. Do we have any takers here? Nope. And first one, please.
I get my epigenetics moment. Okay. On the poster that was looking at all of the epigenetic changes, they were able to identify enhancer regions using what I believe was 2 histone marks.
Yes, yeah. The enhancers were profiled primarily by H3K27 acetyl.
And you're doing the subtraction. They find it in both enhancers and promoters, and then one that's only in promoters, so you're doing the subtraction one. I know that a lot of the stuff that was done recently, they can usually confirm this with like monomethylation, I think on lysine. Are you just gonna follow that up to kind of confirm what you're seeing?
Yeah, so I would say the initial work was done in cell lines, and there we can use ER chip, K4 monomethyl, other marks of active and enhancers of interest to confirm that these enhancers we're looking at are relevant biology to the tumor. And then speaking specifically to the platform of other marks we can profile in patients, that's an area of active development of the wet lab side of what other marks are informative and can be easily profiled. K4, I don't necessarily know is the next highest priority, but definitely additional marks can be useful.
As just a genome-wide view, did you look to see if the promoter regions that those are acting on, are they in cis? Are they localized close by? Or are they potentially way off target and doing something trans?
Yeah, great question. We tend to have more confidence in promoters or enhancers that we know are local to the gene. I did my PhD in 3D genome folding, so I
you want to get your tab boundaries out?
Yeah, exactly. Yeah. So I have a soft spot in my heart for long-range regulatory interactions, but most of these enhancers and promoters that we're profiling are within 50 kb of what we hypothesize are the target genes.
That's really, really cool. All right, thank you so much.
Thank you. So next one, Gaurav.
Gaurav Gupta, University of North Carolina. Congrats on the great work. I had a question for the structural variant-based method. Sorry if I missed it in your poster, but what's the depth of whole genome sequencing that you need for tumor and germline? And what's the efficiency or accuracy of SV prediction, meaning that if you design an assay, how often do you just never see it in the blood because maybe it was a false positive from the sequencing?
That's a great question. So the average depth in our cohort was about 22x. I think the minimum is 15 for the assay, but I'd have to double check that. For the second question, I'm not entirely sure. I think that's more of a technical piece. What we received was the reports of the sort of like the detected, non-detected, and some of the results from the whole genome sequencing, but that's a great question.
So it doesn't say how many targets were detected, it just says, how many copies of something was detected.
So what we received was the number of validated structural variants and the copy number associated with them. So the assay uses from 4 to 16 structural variants.
Okay.
Angie.
Hi, Angie DiMichele, University of Pennsylvania. Great work, everyone. This question is about the neoadjuvant endocrine therapy trial. These have been this has been a really difficult area to measure efficacy of endocrine therapy, and we've really struggled to establish surrogate endpoints here that can help us understand whether patients are going to have a good response and a good outcome because so few patients get a pathologic complete response. So I'm just wondering where you're going in terms of maybe potentially combining the ctDNA outcomes with surgical outcomes, any kind of a new endpoint that you could see being potentially useful in this space. And as a secondary question, can you correlate any of the tumor characteristics to those patients who are going to have a ctDNA response?
Thank you for your question. We have a limited number of patients, so basically it's difficult to make specific correlations, but generally we see in this setting what we already know, that basically having ctDNA is bad, and if it's not cleared and persistent, it's even worse. And basically, I think this work should encourage us to move forward in this field. And I want to echo what Professor Fabrice André said yesterday, that it took 12 years from the MSI high and the PD-L1 detection until we showed it in endometrial cancer. So basically here we have the ctDNA positivity that we always say it's a small number of patients, we don't have a lot, but if you combine everything, we have a super powerful biomarker. And I think the patients want us to act upon it. And until we will get all the technical standardization, validation, and everything, it's going to take a lot of time. And next to my room, I have 2 CT machines, one by General Electric and one from Philips. And when we have a lesion in the liver, we act upon. We don't ask maybe it's false positive or maybe we miss something. So I think we need to move forward and to do trials that basically take the positive patient with the persistent ctDNA and treat them on it.
I want to add on that, and Angie, thank you very much for this question. I think the ER-positive disease is really the most challenging, as we are all well aware, and I want to really congratulate you that you were able to design such a study and to evaluate it, and I think it reiterates the question, how can we define composite endpoint, including ctDNA, including some of the response? It doesn't have to be pathologic complete response or some adapted RCB score for the endocrine treatment, but we do need these trials in order to finally also answer the questions, are those patients in need of chemotherapy or can we treat them with alternative approaches? So congratulations.
Next question, Matthew.
On the same topic, I just want to remind people about the preoperative endocrine prognostic index. So if you give neoadjuvant endocrine therapy and there are no negative patients with a T1 or T2 tumor that has complete obliteration of cell cycle activation, in other words, the Ki67 levels are very low, those patients have excellent long-term disease-free survival. The difficult ones are the ones that have higher sort of risk tumors, and it's a sort of degraded assay according to the level of the persistent proliferation and stage. So that's where I think the interaction with whether they're a shedding tumor and whether there's a ctDNA perturbation could be integrated in the model. But I don't think we should ignore quite a lot of literature on identifying extreme responders to endocrine therapy and build on those kinds of models because people talk about RCB, but really that's a chemotherapy model. There are models specific for neoadjuvant endocrine therapy.
Thanks. You're totally right. We need more. We need better biomarkers, and we're trying to work on it.
Thank you. So I have a question for Dr. Linville, which is, it looked actually pretty good. There was a correlation between the ctDNA and, I guess, classical imaging response in the metastatic setting. And I hadn't seen that in many ctDNA studies. I wonder if you could comment on that and maybe the ctDNA could certainly complement or maybe even replace that. What do you think?
I think we did see that correlation, particularly with that decrease in tumor fraction by 90% for the patients who had that profound response at the beginning at week 1 to 2, that it was correlated with their clinical response at first restaging a few weeks later. So I think that that's definitely positive. We did not see that in our the other calculation that we used to assess for ctDNA level, which was the maximum allele frequency, but that was sort of more of a crude assessment. I think certainly if we can kind of modify and kind of come up with a standard ctDNA level metric that we can all use, then that, and we can continue to see these results, it could definitely have clinical impact down the road.
And just briefly to add to that question, what do you think, what is the right time point to evaluate this response, and do you need just one time point or many time points in order to really assess the patients?
No, that's a great question as well. I think that's sort of what our study was trying to look at, is sort of assessing what is that ideal time point. I think the week 1 to 2 was a little bit challenging, I think, just logistically with some of the start times of patients on treatment and getting that blood draw at the week 1 to 2. But certainly, I think sometime in that first month frame would be ideal to sort of assess that early response. Usually these patients were getting their scans around weeks 8 to 12, and so we sort of already have a pretty good idea of how they're doing at that point, but if we could even intervene earlier, I think that would be great.
Thank you. Dave.
Thanks, Chuck. Dave Chascon from Princess Margaret. Just to follow up on that, so we've done some work similarly trying to understand the sequential time points using high sensitivity ctDNA assays that otherwise might be considered in the MRD setting, Garden Infinity, radar tests, in the first line CDK4/6 inhibitor setting. And I think the key question about the time points is what are we trying to predict and with what kind of therapy and what disease subtype. So in first line ER positive disease with CDK4/6 inhibitor, you're expecting most patients to respond. To discriminate those patients who really respond the best, we actually observed that it takes longer to see those patients who actually clear with an MRD test and then do extremely well, those like exceptional responders. Whereas with treatments where the response rates are much lower and you want to know early, is this treatment going to fail? Because a high proportion of patients, the treatment will fail. Those early response metrics are necessary. But I think this is probably a subtype and treatment-oriented response, not something like RECIST that we can say, 8 weeks, RECIST, this is the 30% threshold that makes a response or not.
You see here, I'll pose maybe the last question to anyone on the panel. Are we going to need maybe different cutoffs for different clinical subtypes? ER positive, HER2 negative versus triple negative, or will one size fit all?
I don't think one size fits all, and we've seen that heterogeneity also in the published poster with the SAGA assay. But I do think that we will need to address which assay to use for which question, and do we probably need combinational assays for some questions in the future.
All right, we're basically right on time here, so I'll thank the poster presenters and Marija as the discussant for doing an outstanding job, and thank everyone for attending.